So good morning Lakeshore family. Pradeep Mathew sir, Iqbal sir, Roy sir, Koshy sir, all senior council colleagues, friends. So today we'll be having our breakfast CME by the Department of Gastroenterology, and we'll be having three speakers: Prof. Koshy, Dr. Pradeep Mathew, and Dr. Maya. The session will be chaired by Dr. Roy Mukkada, HOD of Gastroenterology, and Dr. Antony, senior consultant. So we invite all the speakers and chairpersons to please come on stage and can start the proceedings. Thank you so much.
Very good morning. First of all, let me thank the management of Lakeshore Hospital for giving us this opportunity. Thank Dr. Arun for guiding the program very well. So we have today three talks. The first one is done by Dr. Maya, our pediatric gastroenterologist. This pediatric IBD is a very complex problem. Actually, we know that the children we have been treating has become now adults, but when they become adults, this complications are becoming more, and now the presentation is very different. Pediatric comes with very complicated problems. So I think Maya will give us more enlightenment into this. Dr. Maya, you can start.
Good morning to all. At the outset, I thank Lakeshore Hospital for giving our team this opportunity. So moving to the topic, so this treatment of children who present to us with IBD. So IBD is such a vast topic that we have monothematic conferences going on 2 days, 3 days together, and we're supposed to concise it all into 15 minutes talk. So I will do what I thought was important to present here. So the overview of this talk, the scope of this talk, one is the overview of pediatric IBD. How do we go about evaluating and managing children? Something about monogenic IBD and the management of PIBD. So as we all know, inflammatory bowel disease is a chronic inflammatory condition of the colon and intestine with a relapsing and remitting course, and it has a multifactorial, it's multifactorial in etiology. Here we have Crohn's disease and we also have ulcerative colitis. If you actually look into the spectrum, it's actually one side you have Crohn's disease where you have a Pangea involvement, where you have colonic involvement, you have small bowel involvement, you have upper GI involvement. On the other side of the spectrum, you have ulcerative colitis where you only have colonic involvement, and also there's a small subset of children who could be IBD unclassified, where they present with a predominant colonic symptom, but they actually cannot be classified into Crohn's or ulcerative colitis, and over the years they may evolve into either one of them. Now, just in brief, how do we differentiate? So ulcerative colitis, as I said, it is mainly a colonic involvement. It is a mucosal disease and they're predominantly present with bloody diarrhea. Because of this blood loss, they can have anemia, they can have hypoproteinemia. Whereas in Crohn's disease, it has a Pangea involvement. It can start from mouth to anus. It has a more deeper disease where you have a transmural involvement. So complications like strictures, penetrating diseases, fistulas, all this are more common. And because there is bowel narrowing, they tend to have more of abdominal pain as a presentation. They could also be having subacute or acute intestinal obstructions. Because of small bowel involvement, they could have malnutrition and malabsorptions. As I said, etiology is multifactorial. There is definitely a role of genetics to play. There is also immunity. There is also a role of gut microbiome and environmental factors in this. Now, I'll just start with the case history of a 2-year-old boy who presented with loose stools, bloody diarrhea. He also had perianal abscesses which needed drainage. So he presented to us. When we evaluated him, he was small for his age. There was growth retardation. He was anemic, he had high inflammatory markers, and he also had low albumin. So we suspected IBD. We proceeded to do a colonoscopy and endoscopy, which actually showed that there were deep ulcers in multiple areas of the colon. Our ileum and IC valve was normal. The perianal area, because of his perianal disease, there was scarring. Upper GI endoscopy didn't show much. And biopsy showed deep ulcers, abscesses, granuloma, etc., suggestive of Crohn's disease. Now, whenever there is when we diagnose Crohn's disease, we also do a small bowel evaluation. And here you can see there was some thickening in the ileum, and there was the prominent vasa recta that is suggestive of Coombs sign. So this is child we have diagnosed to have pediatric IBD in this child. So do we need to do any other investigation, or can we start treatment right away? So as I said, so this is how most of our IBD patients present. They may have a constellation of symptoms. They present with diarrhea, they present with abdominal pain, they may have poor weight gain, they may be inflammatory markers high, there may be evidence of malabsorption. Sometimes they would have extraintestinal manifestations like aphthous, joint symptoms. I would be coming to that later. So this is one of the largest series of pediatric IBD from India, and I was also fortunate to be part of the study. So if you look at this, around 325 children from different parts of India, you see that most of them, whether it's GED or Crohn's disease, where all of them have presented with abdominal pain, chronic diarrhea. But you look at the ulcerative colitis patients, actually more or less had a presentation with bloody diarrhea. However, systemic symptoms, growth retardation, all this were more common in Crohn's disease. Again, if you look at the anemia was seen in both clubbing, aphthous ulcers, perianal disease, growth retardation, all this were more common in Crohn's disease. Now, I alluded to about the extraintestinal manifestations. We should remember that sometimes as Crohn's children, 30% of them can have extraintestinal manifestations. And if you look at this, the graph I put on the right side, you could see that up to 25 to 26% of children had extraintestinal manifestations even before their GI manifestations. So they could be presenting to a rheumatologist, they may be presenting to a hematologist because they are anemic, they could be, or they may be with an endocrinologist. Many times I have had cases referred to me by endocrinologists because the child is not growing well. So extraintestinal manifestations, we should keep in mind. We recently picked up a case because of skin manifestation when Dr. Eben referred to me. So these are sometimes the extraintestinal manifestations may sometimes guide you to an IBD. So this is our own data where we found that 30% of children had extraintestinal manifestations, and most common was oral ulcers, arthralgia, arthritis, erythema nodosum, uveitis, pyoderma. All of them were seen in Indian subset of children. Now, is IBD in children different from adults? So children are not small adults. They definitely have differences from from their adult counterparts. So first is whenever we have a pediatric onset of IBD, they tend to be more severe. They tend to have more structuring, more penetrating disease. As I said, they would have growth failure, nutritional deficiencies. They have delayed sexual maturity apart from psychosocial issues. And also in pediatric IBD, we tend to have a subset of children who could be monogenic. So what is monogenic IBD? So all this time we were talking about an IBD which is in adults where you have multifactorial involvement, as I said, like diabetes, it could be genetics, environment, immunity, so many factors play. Here this is an IBD which has a Mendelian like inheritance with the different presentation, different penetration, and they present like IBD. So that is the difference where this is classically different from the classic IBD which is polygenic. And this was first described in 2009 by Glocker, and there he described this pediatric IBD in IL-10 receptor deficiency in a child, and from there's no looking back. There have multiple mutations have been diagnosed, and then we have a whole spectrum of monogenic IBD in pediatric IBD children. So these are more severe and they're more refractory to the conventional therapies. So just a quick overview of how we classify and how we look into this. So this pediatric IBD can be classified, any child less than 17 years is pediatric IBD, and then you have the neonatal onset IBD when it's less than within 28 days, infantile within 2 years, very early onset less than 2 years, early onset less than 10 years. So as the child is younger in its presentation, the tendency of monogenic IBD is higher. So this is another largest cohort where the 1,000 children, they found that 30% of them who had actually exome sequencing, and they found out that 30% of these children actually had monogenic. So, and also the younger the child, they found that the incidence of monogenic IBD is higher. So this is just a spectrum to show that there's different parts of the gut immunity can be affected, and they could have different defects, which could be an epithelial defects, phagocytic defect, T or B cell immunity, IL-10 pathway defects, which I said, or it could be hyperinflammatory pathways. Now, just a quick word about IL-10, which is because this is what we commonly see, and this is what was first described. Just to say, here you find that these children, they present with life-threatening colitis, with perineal lesions very early, with bloody diarrhea, and what we need to remember is they do not respond to our conventional methods of treatment, be it steroids, immune suppression, including our anti-TNF agents, and they need to go for stem cell transplant. So they could have multiple phenotypic presentation, be it infections, it could be autoimmune, because they have an underlying genetic problem. So they would, and they could be, that's associated with an immunological defect. So they would present with many of these manifestations. So that may sometimes be a clue for us to tell us that, okay, this is not a simple IBD or the polygenic IBD, this could be a monogenic onset. And it could be skin manifestations, recurrent infections, etc. So this is what I said. When do you suspect, when a child presents to you, could this be monogenic? Because we can't be sending genetic testing for every one of them. So one is if they have very early age of presentation, or two, if they have multiple family members or consanguinities there, they have severe perianal disease, if they have associated recurrent infections or skin lesions, dental or hair abnormalities, or when the treatment with our conventional medication fails, that's when you start suspecting, could this be monogenic IBD? So if you suspect, what is the algorithm we follow? So then you need to look for is there an associated cell defect, like is there a neutropenia, is there a thrombocytopenia, is there an IgG immunoglobulin levels we need to look for. Rarely, sometimes we can go for flow cytometry if it's available, or if you strongly suspect, we can actually directly go and do a genetic testing where you can do a whole exome sequencing, which would tell you where is the defect. So now moving on to the management. So these are the agents we have. We have one set of agents which we call as induction agents, one is a maintenance agent. Now induction agents are those which helps you to achieve the remission, and then maintenance agents will help you to sustain that remission which we have attained. So whether be it Crohn's or ulcerative colitis, we can use systemic steroids and biologicals, and in a small set of children who have very mild Crohn's disease, we can also try exclusive enteral nutrition, though it's a little difficult to practice it. In ulcerative colitis, aminosalicylates can be tried, and we also have this new small molecule which is a JAK inhibitor, which is presently recommended in ulcerative colitis, tofacitinib. For maintenance, we generally do not prefer steroids. Whatever is the induction, if you use biologicals, we can try maintenance with biologicals or switch over to some other drugs. So maintenance, most of in our practice, we usually use the thiopurines, azathioprine or 6-MP or methotrexate can be tried. And then aminosalicylates are the preferred agents for maintenance in ulcerative colitis. And if they're not able to maintain, then we go up on we choose one of these and continue the treatment. So this is what I said about biologicals which we use in pediatric IBD. So you have the anti-TNF agents where infliximab and adalimumab, and we also have the IL-12 23 antagonists, which is the utsikunel, which is also available present in the market, and we have also tried in some of our children. And we have alpha 4 beta 7 antagonists, vedolizumab, which is also available. Of this, only infliximab and adalimumab are FDA approved for use in children. So they are used as the first line drugs in pediatric IBD, and only if there are failure of anti-TNF do we choose one of the other agents. Now, how do we choose medications? More or less, we prefer to give them a trial with other medicines, and if they are not responding, we consider an accelerated step up in children, because you cannot be trying them with steroids on and off, because growth is also an issue. So those of children who are not responding to 12 weeks of other therapy, we consider accelerated step up to anti-TNF agents, or sometimes certain situations you go for upfront where you don't try other agents, you just try to go for anti-TNF, like when you have growth delay or when you have extensive disease or when you have severe perianal disease, where those are sitting. Sometimes we consider an upfront anti-TNF agents. There's sometimes despite all the medical measures, we may sometimes have to consider taking them up for surgery. In ulcerative colitis, if it is a failure of medical therapy in acute severe UC, refractory UC, they're present with bleeding which is not controlled with other methods or malignancy. Again, in Crohn's disease, when you have a complete bowel obstruction, when you have perforation, bleeding, or localized ileocecal disease with an obstruction, those are some of the situations we consider surgery in children. Now, coming back to our own child, he had very bad perianal disease, he had root retardation, he had deep ulcers, so we considered upfront biologicals in him. And then did it work? It didn't work. Poor response to the biologicals. So that's when we considered, is this a possibility of monogenic IBD? So then we started working out immunologically, and then we also sent whole exome sequencing for him, and this was the report, and he turned out to be an IL-10 receptor deficiency. And so you have a child who has a very early onset, that is, he presented less than 6 years. He has a monogenic onset of IBD, monogenic IBD with an IL-10 receptor deficiencies. So in monogenic IBD, why do we need to diagnose them? If you don't diagnose them, you keep changing the biologicals one after the other. When the child gets immune suppressed, but he will not respond. So you need to pick up this, because if you see this data, you could see that even in the 30% of children in this whole large data of children who had received treatment, 30% of children received biologicals, of only 25% of the monogenic IBDs actually responded to biological therapy. So there is, as I said, in these children, what is the option we have? We can offer them stem cells transplant, and these are the subset of children who the stem cell transplant works, but we should remember there is also a subset of children like your epithelial barrier defects whom this is contraindicated and does not work. So that is why we need to be targeted in our approach to treating them. So there are but still there are some subset who would actually, the anti-TNF helps, like the Hermann-Axby-Pudler, X-linked ectodermal dysplasias. Whereas in CGD, if you give anti-TNF without realizing it is CGD, they would have life-threatening infections. So there are also other targeted therapies for monogenic IBD which is evolving. So let me conclude. Pediatric IBD can present with a constellation of symptoms. 30% of children have extraintestinal manifestations. PIBD can be monogenic in a subset of children, and we need to suspect monogenic IBD in very early onset of children who present with IBD, who are refractory to conventional therapies. Those subset of children, you have to consider thinking about doing a whole exomic sequencing, because hematopoietic stem cell therapy is a definitive therapy in a small subset of monogenic IBD. An early identification and improved understanding of the characteristics of gene in monogenic IBD is important for targeted therapy. So we need to have a tailor-made therapy in children who present with IBD. Thank you.
Thank you, Maya, for that. Please hold on. We'll have one or two questions from the house. Excellent presentation. Pediatric IBD is actually increasing in its incidence and prevalence. We'll ask, let the house have some questions for pediatric IBD. Pediatrician Babu sir, what is your experience of seeing or diagnosing this pediatric IBD?
We had a child last year sent to Maya, diagnosed, and is on treatment. He came for a follow-up yesterday, doing fairly well. And there is another child who was presented with symptoms with the perianal changes. He is coming next week, which are planning to refer to Maya again for workup.
Maya, if the child comes with some lower GI symptoms, how will you differentiate between cow milk allergy or some food allergy from IBD?
Cow's milk children, they present, it has a temporal association with the introduction of cow's milk. The symptoms usually have a temporal association, like they would say, okay, this is the time we introduce cow's milk, and then after that the symptoms would start. Now, by laboratory wise, one is the cow's milk allergy children, they are generally very well looking children, the inflammatory markers would be negative. They only until very advanced stage, they would not have other features like hypoalbuminemia, etc. And sometimes we have seen that they also have skin eczemas. Those cow's milk allergy children would have it's basically a clinical diagnosis for us, cow's milk allergy.
What is the earliest stage we can do endoscopy or colonoscopy in a child?
The earliest I have done is day 1. So endoscopy and colonoscopy I've done 30. You can do in any day, because we have this very small pediatric endoscopes we have in our so we can do at any age.
Any more questions from the house?
What is your experience with Janus sinus inhibitors? Have you tried?
Yes, we We are trying, sir. We have used in pediatric, though it is out of the box because FDA has not approved yet in children. We have used in children and it does have a good effect. But there are reports of vein thrombosis and chicken pox, exacerbations, etc. But we haven't come across any.
JACA used for UC or in Crohn's?
In UC, ulcerative colitis.
Okay, thank you, Maya. Please come. Next, we have Dr. Pradeep on third space endoscopy. You may be wondering what is this third space. Actually, the first space is actually lumen. For us, the lumen is the first space, and second space is the intra-abdominal or intra-chest component, that is peritoneum or mediastinum is the second space. And there is a space between both lumen and this called third space. And now for the last 10 years, a lot of development happens in endoscopy, in third space endoscopy. So let's hear what is new in third space endoscopy. Dr. Pradeep, please.
Thank you, Dr. Antony. I'll jump right ahead and moving on from IBD to endoscopy. This is the plan of discussion. I'll briefly touch on the historical aspect of the third space, describe where is this third space exactly, and a few of the procedures which are being done, and a few words on the future. Now, way back in the 90s, natural orifice transluminal endoscopic surgery was a big thing, where people tried to access the peritoneal cavity using flexible endoscopic surgery. They've actually done in experimental models polycystectomy as well as appendicectomy. However, they had a lot of issues with entry point closure as well as infections and maintaining a sterile field. So this is mostly a proof of principle concept, and it was largely abandoned by the endoscopists. But around 2007, this from the Mayo Clinic, Chris Custout and their group described entering the submucosal tunnel for doing a peritoneal biopsy and taking biopsies from the muscle of the esophageal wall. This was taken forward by Professor Pastricha and again from Mayo Clinic, and they did a submucosal endoscopic esophageal myotomy where they did tunneling using balloons, and they did myotomy of the GE junction. And this is all in porcine models, porcine survival models, and they published this in 2007. This was taken over, this is the basic fundamental principle of the tunneling endoscopy, submucosal endoscopic flap valve. Essentially, they get into the submucosal space using mucosal bleb, enter the submucosa, and work inside the submucosal space using the endoscope and do various procedures, including myotomy as well as biopsies or whatever which needs to be done. So this is the third space. So the GI lumen is the first space, and the peritoneal cavity is the second space, and the potential space between the muscularis mucosa and the muscularis propria is the submucosal space or the third space. This is created artificially by injecting a submucosal solution. Now the prototype submucosal endoscopy or tunneling procedure is POEM, which is described by Inouye way back in 2009, and his publication came out on the first 17 patients where, for achalasia cardia. So this is a motor disorder of the esophagus, patients present with dysphagia to liquids and solids with regurgitation of undigested food. Manometry is the gold standard, and there is no treatment which can restore esophageal function. However, treatment options is mostly centered around reducing the LES pressure. So the standard has always been pneumatic dilatation or laparoscopic Helix myotomy, and in advanced cases or very contraindicated cases, Botox injections. So then came along peroral endoscopic myotomy, which has now become almost a standard of care. So this is one of the older poems which were done here. A submucosal bleb is made in this mucosa, and using special knives, the mucosal entry is enlarged, and the scope is advanced into the submucosal space and dissected in the submucosal space. Repeated injections are made in the submucosal tunnel, and the scope is advanced along into the submucosal space. The issues here which we encounter is mostly bleeding, and the bleeding is mostly managed as basically pre-coagulation. Any vessel that you see has to be identified and coagulated using endoscopic coag forceps. Like that, we proceed deeper into the tunnel and go across the G junction. I'm unable to forward. Each of these vessels are identified and coagulated so that there is no bleeding, and this is the tunnel that you see, and then myotomy is performed about 2-3 centimeters distal to the entry point. This is the mucosal, the myotomy of the circular muscle, and this is extended about 2-3 centimeters below the G junction, and coming back out of the tunnel, the mucosal entry point is closed with hemoclips. So what are the equipments we need? We need a high diffusion scope, we use caps, we only use carbon dioxide for inflation, high pressure water pump and RB-jet. Water channel is absolutely required for flushing, needles, indigo carmine for color of the submucosal space, and we use, the knives that we use are special knives which is primarily derived from endoscopic submucosal dissection. What we use is the TT knife and the dual knife with jet function. And this is the coag rasp that you see there. Hemostatic clips I told, which is for any mucosal entry site injury and for a closure of the mucosal flap. These are the other accessories that we use. Now, can we expect adverse events? Of course, bleeding is very commonly seen, but most of it can be managed endoscopically. Leaks can happen. We use hemoclips. Capnoperitoneum, pneumomediastinum, all of that usually is self-limiting. Pneumoperitoneum is usually managed if it is causing distress or any significant abdominal distension. A Veress needle is used and it's removed. So again, adjustable carbon dioxide pump is very important, and anesthesia support obviously is absolutely key to this procedure. Sometimes unexpected events can happen. This is a patient where we had closed the mucosal entry point, and then on rechecking the mucosa, we saw this bump in the submucosa, and we had to open the submucosal entry point, and the cap had dislodged, which was missed by us, and we had to remove the cap of the end, which was kept at the end, tip of the endoscope. Sometimes using these newer modalities, you can identify vessels before doing the procedure. This newer red dichromatic imaging. Likewise, for even before using the mucosal cut, you can identify the vessels very clearly using RBI. And even when there is bleeding also, it's easy to localize the bleeding using this dichromatic imaging. When there is a mucosal, this is a myotomy being done, and then suddenly the blood becomes all over the place. But if you use red dichromatic imaging, you can actually visualize the bleeding point. What are the results? Results are excellent, 80 to 95% response, but then the issue has always been reflux. And even long-term outcomes, 10-year reports have started coming out, they have got 72 to 95% response. Even Indian studies have come out with large numbers for all types of achalasia, and they've all shown excellent response. What about POEM versus laparoscopic Heller myotomy for type 3 achalasia? They have shown almost 98% response, which is better than laparoscopic Heller's myotomy. Shorter mean procedure time and longer length of myotomy can be done with POEM. What about those who have had previous Heller's myotomy? Almost 80% response, clinical success, that is the Neckar score less than 3 has been documented. So what are the other procedures which can be done using this same tunneling principle? Now for subepithelial lesions of the GI tract, predominantly in the esophagus and stomach, like leiomyoma, GIST, lipoma, neuroendocrine tumors, etc. We use a very similar principle as submucosal, as the POEM procedure. Mucosal entry about 3-4 centimeters proximal to the lesion, make a submucosal tunnel and dissect out the lesion from around the lesion and remove the lesion. This is a procedure which was done about 2 years back. submucosal lesion which is extracted out, and the mucosal entry site closure can be seen easily. Hirschsprung disease is another one. It's a motor disorder that results from a ganglionosis of the myenteric plexus, starting at the rectum and extending proximally. In Amol Bape in Pune did the first per-rectal endoscopic myotomy for these patients, and again similarly they make a tunnel in this rectum, dissect into the tunnel, and then cut the aganglionic segment of the muscle. For refractory gastroparesis, G-POEM has been done. Again, these indications are very limited right now, mostly post-surgical or idiopathic, and diabetic gastroparesis with pylorospasm that are refractory to other treatment modalities. Similarly, in this, they cut off the pyloric muscles. They make a tunnel about 3-4 centimeters proximal to the pylorus, make a tunnel in the esophagus, and in the stomach, and then go on across the pylorus and cut the pyloric muscles and come back into the tunnel and then close off the entry point. I don't have time for the video. Move on. The results, mostly only case series have come out, no RCTs. They have also shown excellent response. Even the ACG guideline recommends this conditionally. Now, the similar tunneling procedures have been recommended even for Zenker's diverticulum. Earlier it used to be flexible endoscopic septotomy, straight away cut off the septum. Here in this procedure, we make 2 tunnels on both sides of the septum. One is in the diverticulum and the other one is into the esophagus. 2 tunnels are made, and the septum is divided using these special knives that we use, and then the entry point is closed off. Now, for complete esophageal obstruction, there are a few reports of what is called poetry or peroral endoscopic tunneling and reconstruction of the esophagus. This is a very difficult situation to treat. So essentially what they do is they make a tunnel proximal to the stricture. They make a tunnel and entry and dissect into the tunnel. This area being very fibrotic, it's very difficult to know where you're going. So an additional scope is used in the other side. If it's in the esophagus, from the gastrostomy side, another tube is placed, endoscope is placed, and this light gives you a direction. And the fluoroscopy also gives you a direction of which direction you're going. And then you tunnel into the fibrotic area. Once you come across this lesion, a wire is placed and a self-expanding metal stent is placed into the new neolumen which has been created. These stents are usually removed in 2-3 months, and repeated dilatations may occasionally be required. An extension of this is what is called the pocket creation tunneling for submucosal or mucosal lesions. Normally we use conventional endoscopic submucosal dissection, and we dissect around the lesion and take it out. But this tunneling makes it much more easier to maintain traction. This is the case where the lesion is very difficult to get around these lesions. So a tunnel is created and completely removed and using this particular technique. This is another example of the tunneling. You can see a large lateral spreading tumor here, and a tunnel is made under the lesion, meaning this part of the mucosa is removed and then completely removed. So the future is already here. This third space provides a relatively safe access route to enter the peritoneal or the mediastinal cavity. Now, GERD was a big issue for all the POEM patients. Professor Inouye, the originator of POEM, has described the first NOTES procedure, or natural orifice endoscopic surgery. They have managed to do anterior partial fundoplication, or a POEM plus F in these patients. And there are also reports of third space endoscopy guided peritonioscopy and mediastinoscopy, and even transcolonic appendicectomy has been reported. This is the basis of POEM F. Essentially, as soon as the tunnel of the POEM is finished, they cut open the peritoneum through the space, enter the peritoneum, and go onto the anterior wall of the stomach and pull the stomach into and make a flap across the G junction. This is how it will look. This is a patient with achalasia, you can see on this side. And post-POEM, there is a large, G junction is wide open, which is what is expected. But if you do a post-POEM plus fundoplication, this is the wrap which has been created using fundoplication. In Inouye's unit, For all echinacea and related motility disorders, they offer POEM. And those with refractory GERD, they actually offer per-oral endoscopic fundoplication directly without myotomy. And those with a high risk for post-POEM GERD, they offer POEM plus fundoplication. So the current spectrum of these submucosal endoscopic procedures involve right from the Zenker's diverticulum, subepithelial tumors we use STIR, echinacea cardia, POEM, strictures we can do POET-TRE, stomach we can do refractory gastroparesis G-POEM, subepithelial tumors again STIR or POE, and in the rectum we can use Hirschsprung disease, we can use PRAME, per rectal endoscopic myotomy. So in conclusion, third space or submucosal space is a novel operating field for interventional endoscopists, and it has evolved over the last 14 years to include various newer options such as G-POEM, STIR, Z-POEM, D-POEM, PRAME, and have shown impressive outcomes. But most of these have been newly described except POEM and require further evaluation in larger studies, but the future looks very interesting. And we couldn't do any of the things that we do without our entire team. Thank you.
Thank you, Dr. Pradeep, for that excellent talk. We started our POEM first time in the state around 11 years back. That was the fourth center in India to start it. So that was a very good experience to continue this procedure because it's exciting and gives good relief for the patients with all sorts of difficult problems. Any questions we can answer? Dr. Lekha, surgeons, any? We could do this procedure. I don't think we could do it without the help of our eminent anesthetists who initially had this technique when they came. This is very important, the anesthesia people to be very vigilant on the readings and then go on. So it's only with the help of our anesthesia department we could initially start and continue. Yes, Dr. Bob.
Is there a role for POEM in pediatric age group, Hirschsprung or echinacea cardia?
Yeah. We do, even pediatrics also we do. Our youngest age is, I think, 9 years and the oldest is 93 years. Thank you. Let me introduce the next speaker. It doesn't require any introduction. Prof. Abraham Koshy. He'll be unraveling the double helix in liver disease. Very fond of genetic studies. He's done a lot of work in that. He's an very in research. Is excellent, and he has got his own publications and in genetics, and he'll be talking about genes and liver. Dr. Koshy.
Thank you. So I'll go straight in with a case. We have a 39-year-old man who came in June 2009 with raised aminotransferases for the last 5 years, that is from 2004. His iron saturation was 83%, normal is 15 to 45. His ferritin level, which is a marker of total body iron load, was 3,500, normal being 30 to 400. His liver biopsy showed grade 4 iron. Normally there should be no iron in the liver biopsy. So this fulfills criteria for hemochromatosis or very high iron overload. These cases are very rare in India. So we did a whole exome sequencing, and the whole exome sequencing showed classical hemochromatosis gene, the HFE, Fe standing for iron, which showed a cysteine 282 position change to tyrosine. So this is the second report of this mutation producing hemochromatosis in India. And this patient was started on phlebotomy, and over the last 14 years, he has done very well. He remains asymptomatic, his liver functions are normal, and his ferritin levels have come down to close to normal levels. This is in contrast. I'll come to another case later, where a patient was diagnosed as having iron overload at another major center in Cochin, but the patient died subsequently. So here you see, for 14 years, we have maintained him asymptomatic. So this particular gene, the HFE, is a gene on the liver cell receptor membrane. Anyway, what you have on top, close to the HFE title, is the blood, and then that serrated linear is the cell membrane of the hepatocyte, and down below you have the nucleus of the hepatocyte. So on the cell membrane you have a receptor, which it's a complex receptor, but includes the HFE and another protein known as the HJV, hemojuvelin. So this complex recognizes iron circulating in the blood and says when the iron is adequate, it recognizes and sends messages down to the nucleus, which transcribes and produces the protein hepcidin. So this protein, if you see on the left, this hepcidin goes from the liver through the bloodstream to the duodenum and tells the duodenum, do not absorb any iron. So this breaks down when these receptors on the liver cell membrane have been mutated. And what we showed, and this is known for decades, very common in Europe and in Australia, where this HFE gene had changed in structure and therefore was not signaling down to the duodenum to stop the iron absorption, and the patient was getting iron overload. It's treated very simply by simply doing phlebotomy, blood donation every month or so, and that kept the patient fine. So the other thing which we found was that two other patients, our patients, did not have the HFE mutation but had hemochromatosis. They had iron overload just like this patient which I described. And they had a variation in the HJV, the hemojuvelin. And this has not been described from India before. And we found a particular variation, the ASP355 position changing to tyrosine, and this variation has not been described anywhere in the world. And we could show that this particular variation changes the structure of HJV, the wild type which is normal is shown on the left, and that structure changes completely where one part of it is split open. And this abnormality again produces a lack of transmission of the messages of iron being present in the blood, telling the duodenum not to absorb iron. So since that is broken down, the patient absorbs iron and gets iron overload without limits. So in Lakeshore, we have done whole exome sequencing for 92 patients. There are some reports yet to come. We are close to 100 now. And about a third of them we find what we call pathogenic mutations. There's an American College of Medical Genetics classification which classifies these variants. And it's like pathogenic, and some are likely pathogenic and some remain unexplained. Now I'll come to something current, not what we are doing, but in the world what is current. So we have had COVID, just recovering from it now, and we have had the COVID vaccine. And this year, It has been recognized by the Nobel Committee. And what Carrico and Weissman showed is that unmodified mRNA is sensed by the antigen sensing cell, the dendritic cell, and usually produces an inflammatory response. Now, in a vaccine, we don't want an inflammatory response. We want an immunological response, but no inflammatory response. And this inflammatory response is necessary for fighting viruses and bacteria, and is also involved in autoimmune diseases and cancer. So what they showed that if you modify the base by attaching something, a methyl group or some other similar group, a pseudouridine, then the inflammatory response does not occur. However, the antigen presentation by the antigen presenting cell increases. The protein presented to the T cell increases, producing more immunological response. And the demonstration of this is what led to the mRNA vaccines for COVID. And this is why Carrico and Weissman received the Nobel Prize this year. Now, going to the future, it's been shown in animals that you can produce here the envelope in which you have packed this mRNA is non-immunogenic, whereas in the COVID vaccine, it's an immunogenic package. So when you put it in a non-immunogenic package and send it to the mouse, and then it's taken up by the dendritic cells, then it triggers the T regulators so that the T regulators suppress the T cells from producing an inflammatory response. And this will alleviate an experimental encephalitis in the mouse model. Actually, this encephalitis, autoimmune encephalitis, has no specific treatment at present. This principle, and it worked very well in the mouse, both that you can do it as prophylactic and at the onset of the disease you can prevent further deterioration. So this principle can be used, it will take some steps before it comes to human, but this principle can be used to treat autoimmune diseases, including allergies and liver transplantation, immunogenic response. It can be used to treat diseases like this encephalitis or multiple sclerosis, and it can be used to treat cancer. So this, I expect that in the next 5 to 10 years, that this will start coming into focus. So to summarize, I think there is a potential need for whole exome sequencing into 1 to 5% of the patients who come to the hospital. Whole exome sequencing is likely to be diagnostic in about 20% of the patients. We had higher because we highly selected patients. It may save the life of those in whom we can make a diagnosis, may save the life or change the treatment course in about 20 to 50% of the patients. And in future, we expect that future vaccines, including mRNA vaccines, tolerogenic vaccines, would be used to treat autoimmune diseases, including allergies and liver transplant management, immunosuppression, and cancers over the next 5 to 10 years. Thank you.
Thank you, Koshy sir. It was a very crisp presentation. Whenever we study hepatology, we always keep the chapter on genetics. But for Koshy sir, gene is just like to masala dosa to us. It's Doppler search. You get Doppler search by seeing genes. So that is what we have seen. We did a lot of study from our department on genetics and liver disease. Sir, is there any genetic therapy, gene therapy available for any disease as of now?
No, gene therapy has been being tried for the last 10-15 years. Then because of some mishaps, FDA actually stopped further trials for some period. It has restarted now. Yeah, it has been used in case reports. Are there few cases as a sort of bridge to transplant, where they have temporarily done it, but it's not coming to, it's not FDA approved or it's not coming to vote yet. But a lot of work is going on. It will come in future.
What is the tissue we sent for this whole exome sequencing?
Oh, just blood.
Blood is enough.
Yeah.
This floor is this is open to the floor for further questions and comments.
Since sir has mentioned about liver transplant, already some centers are routinely doing this genetic analysis to find out a group of patients who will have resistance to tacrolimus. There are a group of patients, they are called hypermetabolizers, who have mutations in cytochrome genes, and they tend to reject despite receiving adequate immunosuppression. Such patients can be identified preoperatively. Some centers are routinely doing, but I don't know the cost involved. That's why
It's come down a lot. When we started, it used to be more than 1 lakh. Now we are doing for 16,000. That's a special rate.
One more thing I wanted to ask you, sir. Is it similar to NGS? Sir will be doing
it's the
just
same thing. It's the same thing.
same thing,
Yeah.
just like done in lung cancers to panel.
Whole exome means we are looking. There are two ways of looking at it. You can look only at the exomes. You have introns and exons. So when you look at the exons, you call it exome. Otherwise, you can do a whole genome. But the interpretation of whole genome is much more difficult, and the additional information is also limited. So predominantly now it is whole exome, and clear guidelines are there on how to do and interpret exomes, but not for the genome.
Thank you.
If there is no further question, thank you, Koshy sir, for that excellent deliberation. Hand over to Arun for conclusion.
Thank you, Koshy sir. We will end up this session. Thank you, Roy sir, Dr. Antony, Dr. Maya, and Dr. Pradeep.